Welcome to the Grand Rounds for the Underground podcast. The views and opinions of the speakers are their own and do not represent anyone else's. Let's get to the podcast. My co-host today is Mike, and we have Nick as our guest. We want to welcome you to the podcast. We're going to talk about veteran healthcare challenges. So let's get started.
Yes, good morning. Thank you so much for having me on the podcast, Rick and Mike. It's a pleasure and honor to be talking to individuals at the Joint Special Operations Medical Training Center, right? Instructors who know medicine in and out, especially as it impacts our veteran community, the Special Forces community in particular. But it's an honor to be here. Thanks for having me. It's a great time to be talking about veteran healthcare and the outstanding scourge, really, and I mean this in a negative way, that is occurring in the community from a after service in the VA environment. Like 18 million veterans in the U.S. Only half of them go to the VA. We only go when we have to, but nonetheless, I'm not a medicine man, so please, I'll preface everything I talk about medicine as do your own fact checking, do your research. But I'm an engineer by trade and also a veteran of the U.S. Air Force. I was at Air Force Special Operations Command for about 6 years, 2010 to 2016. Spent a good amount of time deployed, mainly to Afghanistan, Djibouti, where we'd go launch to Yemen and northern Somalia, and then Kenya, where we'd do some missions in southern Somalia. And then after my 6 years in the Air Force, I went to go work for a contractor, a customer being so common. It was great. We were stationed out of Crete, Greece, and we'd fly down into Libya every day and conduct our missions against ISIS down there. Very interesting mission, very gruesome, by the way. ISIS was a totally different ballgame. I remember even Al-Qaeda was coming out and saying, well, we don't associate with ISIS. They're crazy. That was it was weird. But I was telling you guys a little bit about my mission with Air Force Special Operations being in a small surveillance aircraft. So there was quite a bit of gnarly stuff that went down. Actually, proud to say that we've supported the ODA team in many cases. Eyes in the sky. I remember my first I didn't even know what we were doing, right? Going through training, having a security clearance, top secret security clearance. I didn't know exactly what I was doing or going to be doing in the military until like my first mission in Afghanistan with a trainer next to me.
Wow.
And I remember it well. We were supporting an ODA team. There was also some Afghan National Army there, and a compound. We were doing a raid on a compound that had been watched for quite some time, likely months. Lots of activity, multiple buildings in the compound. And we got there that night. It was dead silent. And they had the dogs out sniffing from building to building. We're like, all right, well, either they knew we were coming or, what you could imagine is the worst case scenario. The one shed that had a deadbolt on it broke the deadbolt, opened the door. Everybody, all of the mams, as they say, waiting in that one little shed, and just opened fire on everyone. And so I was like, okay, so this is what my job is, and it was difficult. I came away with a little bit of PTSD. I say a little bit, but I struggled with it for years going to the VA every couple of weeks for talk therapy. I think it was my third visit that I was referred to the psychiatrist and went down this path of what they call like polypharmacy, right? And by the way, there's a stat we could look up. The mortality rate for somebody on polypharmacy, especially into middle to upper age, it skyrockets. But anyway, as you can imagine, as I'm sure you guys are used to, SSRIs, stuff to get to sleep, stuff to wake up, stuff for the pain. I also had a fractured spine coming out of the military, something else I wanted to talk about is like the disclosure problem we have. And it's this system where we're penalized if we go to the flight doc and tell them anything, right? Like, yeah, you're going to take my wings away, you're going to take my clearance away. And that's just crazy to me. It's absolutely insane. And so 8 years in the VA system, polypharmacy, my older brother actually, he introduced me to integrative medicine. I didn't even know what integrative medicine was at the time. As many people are in the same boat today. And it's probably worth a quick definition, at least in my opinion. And You guys
I
tell me
agree.
if you agree. But
Yeah.
so integrative medicine, as it sounds, takes the best of all the modalities, right? There's, I beat up on conventional medicine a lot, but really, it saves lives. There's no question about it. And there's absolutely nothing wrong with someone easing pain, easing symptoms. But in the meantime, let's take and borrow modalities from from other types of medicine, functional practices that promote a healthy lifestyle, nutrition, stress regulation, sleep, even, a lot of Eastern medicine, right? Like, sugar in Western countries probably the best example, but we, we understand its inflammatory properties, its
Hmm.
association with neurodegeneration, Alzheimer's, and that sort of thing. So I like the let's call it what it is. Let's call it, sugarification of the brain, right? Like
Yep.
this
Yeah.
neuroinflammatory, and it's not just that, but these things don't get talked about at the halls of the VA, at least to patients, right? Like I remember
Yeah.
taking my therapist to task years into my therapy as I started learning some of these things. Like, hey, not once have we talked about the importance of like gut health to brain health, or the fact
Yeah.
that I was put on an antibiotic regimen every time I was deployed, sterilizing my microbiome, and then we all
Killing
wonder
Yeah.
why.
everything. Good stuff,
Yeah,
bad stuff. That's the problem.
yeah,
Yeah.
right,
Hey, man, give me a Z
right,
pack.
yeah, exactly. It was no problem getting downrange first day. As you're checking in, you go to your flight doc, you get your 30-day supply of Ambien. Of course I'm tired, like, and then, yeah, we wonder why we have dysregulated systems when we go out, and we treat it with talk therapy and SSRIs and sleep medication, and then we'll give a veteran a free yoga class and call that whole health care. Like that.
Well,
That's
a lot of times,
That's not it.
yeah,
but a lot of times they're treating a symptom. They're not sussing out what is causing those symptoms. You
The
have
root.
one system, hey, your cholesterol's high, take this pill. Not, hey, you need to adjust your diet, you need to exercise. Let's find out why your cholesterol's high. Is it because of poor insulin tolerance in your body, and what's causing that? Can we remove that, and will that fix your cholesterol, your LDL, your triglycerides, or should I just give you a pill? And a lot of people, all they want is the pill. They don't want to change their lifestyle. But at the end of the day, we talked about sugar. Sugar is ultra refined, and if pure cane sugar it's the poison's in the dose. If you take too much of anything, it's not good for you. But sugar in limited, if it's pure cane sugar, it's not as bad, I think, than the ultra refined, your processed foods, your all of that stuff that goes into your dietary, your input for your body is part of it. And we're horrible at eating healthy, I think, for the most part.
I
yeah,
think we can
you
all
got that
agree
right.
that there are times when polypharmacy is a good answer. But the problem with polypharmacy is it just layers and layers and layers of masking what's wrong, trying to fix, like Rick said, this or that, instead of fixing everything, like a good lifestyle, like being a good person to yourself. Yes.
Yeah, yeah, it's a worthy cause, even a noble one, to reduce pain and minimize side effects. But like I said, in the meantime, let's
Yeah.
let's try to figure out the actual pathology and get to the root cause. And like SSRIs, right? Like my PTSD, it came in the form of depression and
Hmm.
anxiety and sleeplessness, and tried a few different versions of it. A few of them helped a little bit. It numbed the symptoms, but it also numbed everything else, like
Hmm.
including my
Yeah.
ability to connect with loved ones, even just feeling dull, emotionally mute. So there's all these layers of side effects now that we're going to start to treat with a course of, it's so integrative medicine. Getting back to that quick
Yep. Sorry.
definition is borrowing from all the modalities, evidence based, of course. But there's this idea that if if something doesn't have a double-blind, placebo-controlled study, that it's not evidence-based. And I challenge that in some ways, and I understand the importance of human trials, especially when we're talking about, lab-made foreign substances. But also, let's not dismiss the millions of anecdotes that are all echoing in unison in the veteran community, that are we're now stomping our feet and saying, hey, this is how our lives are day to day. This is how we feel. These are the outcomes of this fractured system that's been in place for who knows how long. And it's encouraging to see, as I talk to folks, even at the VA. And I want to be clear, like, it's every time I talk to a staff member, a healthcare worker at the VA, they applaud and are of a like mind. And of course, they alone, or their department, their VISN even, can't make an institutional change. So I also want to put that out there. Like, the healthcare team, my primary care at the VA, they're using the tools that were given them. The
Yeah.
formulary is a very, I guess, entrenched is probably the right word at
Yeah.
the VA, and good luck changing it alone. And so we started the nonprofit that I'll talk about in a minute. But
And I agree. The
anyways,
VA are generally great providers in a poor system. Hands
Yeah.
tied, kick them in the water, do the best you can with all you can without any of the resources that are really effective. So I agree. I've had
Yeah, and
great providers.
there's some limitations there in the structure of the system, but it's a human system, and humans. I mean, I've got a really good provider for my primary care. He's pretty open to things. He's a former Army PA, yeah, good guy. But some of the other providers, it's hit or miss, and how open they are to things. There's a lot of regimented treatment modalities that are locked in. I do question how much freedom they have to modify treatments outside of that algorithm. So that's kind of interesting. Yeah, we'll dig into that.
yeah, yeah, and that it ties back to what integrative medicine is, and I think the VA started getting there with their whole health initiative. And every visit, I think, has a different definition in how they approach it. But for me, in my care path, it was a simple, like, let's broaden the scope of a few labs. Let's take a look at your hormones, which, yeah, I couldn't get done at the VA. And that's a hot topic right now. I want to talk about that too. But,
Yeah.
and, uh, and also just a few other panels that might reveal deficiencies. And it did for me. A few simple deficiencies. The one everybody's deficient in, vitamin D, DHEA. My total testosterone was fine, but let's go a few layers deeper. The free and bioavailable weren't, and that gets missed in a lot of cases. Once I corrected those few things, it was able to spike some mental clarity and a little bit more energy, just what I needed to start practicing a healthy lifestyle. I didn't have the motivation. I didn't care at all. I just cared about not and being in less pain, being able to get out of bed in the morning because of my back injury. Our telemedicine clinic is called Renew, RENEU, and it's a play on words for, like, the first step in everybody's journey in getting healthier is renewing the mind, starting
Mhm.
starting in the mind. You said it, Rick. You hit the nail on the head when you said a lot of people kind of want the easy button. And we see that all the time in the clinic. And we've even had to deny, like, GLP-1 usage to people who just aren't taking care of themselves. And they're complaining about side effects. Well, yeah, you're malnourished. You're not
Yes.
Yes.
exercising.
You're dehydrated. You're
Yeah. 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 And then the headlines appear, oh, GLP-1s are dangerous. And, well, let's talk about responsible use. Just like you guys
Yeah,
said, anything
they
in
they can be
excess.
dangerous.
Yeah. Yeah.
No, we've mentioned integrate. I can't say it.
Integrative. Yeah.
integrated.
Integrative medicine, and we've talked about it a little bit, but we haven't defined it. So I pulled it up on the internet. It's defined as it's an evidence-based approach that treats the whole person, mind, body, and spirit by combining conventional care with complementary therapies. So that's basically, I'm assuming that's what we're talking about. That's the overall kind of broad gist of
Yeah.
this.
And I
Right.
would say the internet got it right this time because it usually doesn't. That's a pretty good, in my opinion, not knowing as much as you do, I think that's a
Yeah.
pretty good definition. Good job,
Yeah.
internet.
It borrows from modalities from all medical disciplines, what I would consider like conventional, and that's how
Hmm.
I describe the VA. Although, like I said, their whole health initiative, and that's many times used in the definition is considering the whole person. It's not just talk therapy plus drugs plus yoga class. That's a good start, but it to me it's the interconnectedness of like the definition gave your mind, your body, understanding that the gut brain axis, that serotonin is manufactured in our gut, and what we feed our gut is going to influence I mean, especially, as we age, we see it right away. If I eat a ton of sugar, tomorrow I'm feeling like crap. That's inflammation. That's your brain telling you like, whoa, pump the brakes.
Yeah. Everybody likes
And
some good pizza every now and then, but it shouldn't be
it,
every day.
yeah,
Yeah.
yeah,
But I mean, it kind of goes back to you mentioned, adjusting getting some labs done and finding out some of the root causes, making a few adjustments for you made a difference between surviving, getting up and trying to survive each day to actually living and being able to, take control of your life and live a better life, a more satisfying life. Would that be an accurate summation?
yeah. Absolutely. Yeah, it's once I had that energy and some increased mental clarity, now, other things become easier, right? It's easier to get up earlier in the morning and get your rear in the gym, right? Like it's easier to say, okay, well, now I'm putting the effort in, so I'm not going to take two steps backward with my visit to the pantry. And now, not to say that that doesn't happen ever, but right, like we're all human.
Yep.
But as you begin to stack these healthier habits day over day, we all know it, right? It's obvious. It's the consistency, but that's a lot harder when you're just struggling to survive mentally,
Right.
physically,
And
spiritually.
I can empathize with that. I mean, I don't think there's any of us that don't struggle with that in some form or another. And I know that, like, for myself, I try to work out every day. If I get 3 workouts in a week, that's a good week. To be honest, but it is that struggle for fatigue. I wake up early in the morning not because I'm well rested. It's because I woke up through the night and I wake up and I'm tired and I'm not sleeping well. So how do I fix that? And there's a whole list of ways. Right now it's kind of up to us to take charge of our own situation, our own treatment, to do some research, go to your doctor and say, hey man, have you heard about this? And a lot of times they're like, no, what is that? And you give them information and it's like, dude, I'm coming to you, you're supposed to be the expert, and I'm having to do all the homework and I've got a day job. I've got a family. I've got all these other things. So what are we doing here? And I think that kind of leads us into your nonprofit. So what is your nonprofit? Let's start there.
Yeah. Yeah. So our nonprofit is the Alliance for Responsible Medicine, or ARM, and it is the vehicle essentially for delivering integrative whole person care to the veteran. That's our initial pilot program here. It's a worthy first step. A lot of the folks involved with the nonprofit are veterans themselves, and we've split this up into 7 different pillars, of which touch medicine. And I'm not going to go through all of them, but of course, integrative medicine being the foremost. And Dr. Nisha Money, who's actually a CMO at the DoD for integrative medicine, she chairs that seat.
Okay.
And the veteran pilot program, the I'm actually announcing this for the first time, but it's Dr. Jason Chen is going to be leading as medical director
Okay.
for our veteran pilot within the nonprofit, and
Nice.
he's perfect because he founded the very first integrative clinic at Johns Hopkins. He's a huge patriot, loves the veterans, and understands, how to approach this community and other vulnerable communities with the care that they need. And it's as simple as that. What does the person need? If it doesn't exist in the VA, let's get it to them in a different format or a different clinic, community care. There's all these clinics coming together now as collaborators within the nonprofit so that we can deliver both technology, which I want to get into, but also the one-on-one care that's needed. It could be counseling. It could be, where it's legal, psychedelic therapy, peptide therapy. Yes, let's take a look at people's hormones. I think that's been overlooked for so many years. When we take those first few steps and we start like tuning in, listening to the signals that our body gives us, I'm promoting, and it's part of the function of this nonprofit, is delivering the data, whatever these institutions need. The VA, TRICARE, commercial payers, they want data. Let's figure out how to get it to them, protect the veterans' privacy at the same time, and get these institutions to start paying for the care. I'm promoting, and this is going to be a longer term project, but what'll be called like the Veteran Integrative Care Account, like a VICA or something like that, where, how much did the VA, what's their budget, like 400 billion a year or something like that? But I bet you if you took a third of that and if we put it into some sort of like HSA type account for veterans and let them decide how they get their own care. If they want to go to the VA, great. If they want to go to the clinic down the road, see Dr. Chen's in his clinic, and or go to Colorado and get psychedelic, assisted therapy, let them. And so the Alliance for Responsible Medicine is essentially inviting all the experts into the room, integrative medicine, safety and compliance, technology, and figuring out how to get this done together.
So basically, the nonprofit is trying to get all of these participants in the room to discuss and change policy. Because when you talk about the individual provider, they're limited. So when they see a patient, they can refer them to another service, but they can't necessarily say, "Hey, yeah, man, I can make the VA pay for your psychedelic treatment in New Mexico or wherever." You're talking about overarching, looking to change, I imagine, not just VA, but in the military healthcare system also. Would that be accurate?
Yeah, absolutely. And I think opening up the door for veterans to have more freedom and deciding, putting, the power of proactive healthcare decisions back in the veterans' hands. So there's a stat out there within medicine, the hyperinflation is absolutely crazy, and it exists. I mean, we know fraud, waste, and abuse, right? But we'd preach it all the time. But while we're watching it happen all over the place, where since 1970, medicine in particular has that the administrative costs within medicine have inflated by 3,000%. And there's something going on there, something curious, because every other industry has been able to reduce their administrative overhead. The advent of technology, right? Medicine is the absolutely obnoxious outlier. So if we took a portion, just a small percentage of the VA's yearly budget and put it in an account for the veteran and allowed them to decide how they get their health care, I think that it would make the veteran happier, healthier, save us taxpayers money. And so that's the long-term goal. Like if I were to start at the end in describing the nonprofit, it's giving the data, like collecting the data in two different ways. And this is an important distinction. HIPAA compliant identified data where the veteran can consent to sharing their longitudinal health record with their provider, whether it be their primary at the VA or a different clinic. And then in a de-identified, more research-based function, taking that demographic data and producing, hey, if there's 1,000 veterans that want to participate in a psilocybin treatment in Colorado, let's enable that in a controlled manner, collect that de-identified data and self-reported outcomes and deliver it to who needs to see it so we can institute changes among these institutes. So, but right, the data collection is the challenging part. And so what we've done is built a platform, and this is a pre-launch where we have a registration form on our website, armedicine.org. But in any event, starting with the end user and putting a tool in their hand that can collect everything from, you have decades of medical history. Every time you get a new lab done, now there's dozens of more biomarkers added. We have constantly changing markers delivered by like wearable biometric devices, right? How many data points are considered in your conventional 15-minute appointment? Like, whatever that lab says and whatever your doctor can remember from your medical history, right?
The 5 seconds of basic vital signs the nurse got just before the doctor
Yeah,
walked in. The doctor probably just going to look at those. Yeah.
right, right.
Real quick
And
though, you brought
yeah,
up your website. You have a phenomenal white paper free to
thank you.
read off your website, and some of the stats you brought up when I was reading, and then again last night I reread, and this morning I reread it because there's so many amazing stats in there that it just blew my mind. So I recommend everybody go to your website and read that free downloadable white paper. It'll blow your mind, especially if you're a veteran in that program. Yes.
Yeah, it is mind blowing. And sometimes it's a little disheartening looking at these
I
stats,
would say
but
infuriating because I was a little bit
yeah,
infuriated. Not at
yeah,
your paper, at the information that you gather is
right.
like, wow.
Yeah.
I mean, it's really disappointing that, our systems gotten this way. You talked about the increase in cost for healthcare. And we've kind of watched that, and I have ideas as to how that came about and why. And it's not just one thing. It's not just, hey, this company's greedy. There is some greed there. There is some, hey, let's build all these administrative things so that we can hire all these other people. But if you look at even med school, how expensive med school is, and the universities, and how they've grown their staff and their administration over the decades from what it used to be, and that has driven up the cost of the education, which drives up. So now you have physicians that cost a lot more. They're in debt. We have to pay them more. They have to pay back that debt. It takes them a decade or more to pay off their student loans. So we're paying, and it's not just the doctors, the hospital, the staff, the facilities, all of the prices. And as technology's gotten better, all of that technology has to be paid for. So that drives up the cost. And we end up in this place where, hey, how do we afford healthcare? Once upon a time, you would pay for your doctor visit out of pocket. They're starting these. There are providers who will do routine care. You sign up this co-op, and you pay so much a month, and they'll take care of your routine care. They'll take care of your prescription, your primary care stuff. Anything outside of that is up to your insurance. It's a lot. Some of them are a lot cheaper than the traditional going through your insurance, and then you're limited into providers. You can lose a provider over a change in policy at an insurance company. You have insurance companies that are practicing medicine, in my opinion, without a license, that are denying care. We don't cover that. But the doctor said, this is what I need, and you're saying no. So you're denying me the care that the providers. So we have all of these issues. When you look at trying to fix that system, that's a huge lift. That's a huge shift. And I think this nonprofit has potential of being a start of addressing some of those issues. I think the more people that sign on to this and commit to this, that you can kind of build a kind of collective bargaining type organization to push changes in policy and procedures within government healthcare, and hopefully that bleeds over into civilian healthcare as we show some benefits from this. Anyway, that's
And
my two
you were
bits.
talking about integrative medicine. That's the last I in your aim.
Hmm.
Can you tell us about what the first AI is?
Yeah. Yeah. So, Mike, you mentioned I guess, the justified hesitation with AI, especially as it begins to permeate medicine. And I have that same like check in my gut when we talk about this. So AI plus artificial intelligence being deployed within integrative medicine. So touching almost every part of medicine. It's a hot topic. It's one that, as I travel around, talk to people, go to conferences, there is an incredible amount of noise, and it gets annoying. The amount of companies out there that are like, yeah, we're AI company. It's we're vibe coding an AI app, and it's really the responsible deployment, hence combining it with the Alliance for Responsible Medicine and bringing the leadership into the room. So, National Association of Boards of Pharmacy, their just retired president Jeff Massaros, he's chairing that seat for us. They've also, under his leadership, launched the Research and Innovation Institute, which we haven't started this program yet, but it's on the docket, where you take every aspect of medicine, and now we're touching it with AI. It has to be a good problem solving model, number one, and number two, it has to, in my opinion, this is what I see at these conferences when these AI companies they're just trying to increase throughput. They're trying, yes, reducing clinical workload, administrative burden. That's all great, but our docs are already seeing 20 to 25 patients a day, and they're like, well, now with the reduced workload, you can see even more patients. You can cram more 15-minute back-to-back appointments throughout the day. My opinion is, hey, let's use this. This is a once in a forever opportunity to slow things down a little bit. You were talking about med school. If let's teach more soft skills in med school. Let's enable the clinicians to really develop relationships. Something AI will never be able to do is that relationship side, the trust side. Yeah, we can synthesize thousands of data points within
Hmm.
seconds now, and really deliver precision integrative data to the clinician, and allow them to do what traditionally took hours of synthesis. And that's why conventional medicine just doesn't touch this. But you have some boutique clinics, like you were saying, Rick, like direct primary care. They're they can take their time. They're not beholden to the infrastructure and insurance system, and they can put in the hours. So, but this is a unique time in history where we can use AI for the exact good that it should be used for. Take that, your decades of medical history, and surface it and flag it in every appointment. Anytime a new lab is taken, or a medication is considered, a treatment protocol, it's considering all of those data points at once. That's humanly
So,
impossible.
Hmm.
So, yeah, go ahead,
can I play devil's advocate for a moment?
please. Yeah.
I mean, I've used AI for research, for looking stuff up, and when you say, "Hey, list the sources," it lists a bunch of sources, and generally they're good. But if you check them, sometimes they're not. Sometimes they're made up sources. Some AIs aim to please more than they aim to be accurate, and I think they're working through. That's part of the growing pains with development of AI is, the accuracy and the factuality of the results that you're getting. Is that something that you guys are aware of and trying to mitigate?
So I am a self-proclaimed techno retard, and I'm sure that everybody who's met me would be like, "Yeah, that's accurate." Caveman extraordinaire. In the last few weeks, I've done a lot of AI study, and in my opinion, and I'm probably the last person to know this. Everybody probably already knows this on the planet, but you can use AI one of three ways. You can have AI search just the internet for information, and as we all know, the information on the internet is whatever you want to put on there is on the internet. Or you can use it direct source only, like upload, for instance, like, medical journals, medical textbooks, and then it will only search that. Or you can do a combination of both internet and those to get yours. And I think, Rick, that's the problem, is most people just leave that little button check, use the internet. So it does a little bit of source and a little bit of internet, and you get information that, even I can put out on the internet fake. So
Yeah, there are programs like Open Evidence that a lot of providers use to dig into things and research things, and it seems to be fairly reliable. That kind of is what drove the question. How's that
Yeah.
being addressed?
Yeah. Open evidence is a good example of how this can be approached to increase accuracy and ensure we're approaching this responsibly. Open Med is another one. It's a newer model that we're implementing. We're in it is new, so like we're approaching it in an exploratory manner to make sure it does measure up to our expectations. And Mike hit the nail on the head, right? Like there's most people, we think of AI, we think of the chatbot, ChatGPT,
Hmm.
Claude. That's how the vast majority of people use AI. And I think I was just looking this up, but like there was like 55 million Americans, something like that, used AI to research their own personal health information. And what that looks like 9 times out of 10 is, yeah, I have this symptom. And then, they put a sliver of information in there
Yeah,
and then rely on whatever gets spit back out to then take action on their own healthcare. And while I think it's good that people are being proactive, it can be dangerous, right? Like it can
absolutely.
hallucinate.
Well, if
And
you
so
look at
putting
that
guardrails
number,
around it.
if you look at that number, 55 million, if you look at the population of the United States, I mean, that's 1/6. And you're talking about every person in the United States, not every person of internet age. You're talking about infants. You're talking about, people in old folks' homes. So that's a significant number.
Yeah. And I think it about doubled from the year previous in 2024. And so it's on this hockey stick curve. And I think, you know, Anthropic, by the way, that's the model we're using for a lot of our data synthesis work. These, you know, ChatGPT is no different. They're implementing these features so you can connect your Apple Watch. It won't connect you to a clinician. I think that's really what it's missing is number one, the human in the loop. And what we've done is obviously put it inside of like a compliant database, HIPAA compliant, of course, secure, with guardrails around it in terms of the research that it can access, but also ensuring that any clinical protocol is reviewed by a licensed clinician. That to me is like the most important part. We can
Oh, yeah.
make the clinician's job easier by giving them decades worth of information surmised down to a few bullet points with the highlights and make their job many times more efficient. But absolutely not removing them from the loop. I think the pilots that are going on in like Utah right now, I know it's just for like medication refills, but it's a slippery slope. And, it's going to be done in the matter of the next 5, 10 years, right? Like people are going to try to figure out how to replace clinicians. And I think it's
That
absolutely
is
backwards. Like I said,
Yeah, that's a
yeah,
huge
yeah,
concern because I mean I've had family practice docs that said, "Hey man, AI is gonna replace me. It's gonna replace I'm like, hey, how can that be? Because as a primary care, yeah, there's a human aspect to that, and the way I speak to my computer is different than the way I speak to a human. Human can pick up a lot of nonverbal cues. We do physical exams, interpret labs, which an AI can do conceivably, but it can't do the physical exams and kind of analyze the results. But it takes a human to kind of do the exam. Sometimes the results aren't cut and dry. It's not black and white. It's like, hey, I did this, I got this result. It's like, hey, this seems a little bit off. Maybe we need further studies. That's a human aspect that I think that to a certain extent we need to safeguard in medicine.
yeah,
But like you were
yeah,
saying, Nick, I have two really good friends. They're both retired Air Force docs. They have a clinic down in Tampa, and they were just telling me recently, part of the reason to me actually start listening and thinking about AI was they take all their notes for X patient, they run them through AI filter just to be able to bullet point stuff to make it easier. That way they're not using their whole health medical record plus their, current visit stuff like that to be able to give them clear, concise points takes, 10, 15 minutes versus an hour to get all of the information,
To
all the
read,
stuff together. So
research,
I
and
agree. Super
organize.
helpful.
right, right. And it doesn't miss things. You talk about someone with years of medical history and dozens of markers with their labs, and as I was mentioning, wearable devices now, like it's just humanly impossible to consider all those data
Hmm.
points. And I think sometimes, right, like we talk about over testing or too much information, going on fishing expeditions, that goes away now when you can have a machine analyze all of this data and flag corollaries, right, or trends. And and knows the links, can look at the evidence very quickly and say, oh, well, I noticed they were on an antibiotic regimen for, 6 years,
Yeah.
and they're having mental health issues now. Hey, let's talk about that. Or another example I use all the time, and I was having this conversation at a veteran conference with the chief nurse over Western New York, VISN at the VA. And she agrees wholeheartedly, but she was tabling for disability benefits for like toxic burn pit exposure. And that, in the last several years, it's been a hot topic. And
Hmm.
I think maybe we can get disability for if we present with an illness or a disease as a result of toxic exposure, we get a disability rating for it. And I was like, okay, well, that's a step in the right direction. But I was like, what? We know we have a registry now. We know the people that are coming back from burn pit locations. Let's give them a tox screen. Like
Yeah.
that's a functional test that you just
Yes.
won't hear about in the VA. Why can't we detect elevated levels of toxins and then go through a regimen or protocol or whatever to help to mitigate that? That before they get sick, before cancer, mesothelioma, or asthma
Yes.
kicks in, right? Preventative medicine, and that's only made possible when we can consider all the data points. Direct primary care boutique clinics have been able to do it. It's just not possible in the conventional 15-minute appointment model.
I know that we kind of touched on that the past 10, 15 years with lead exposure from ranges and all that. The military paid for studies, and we determined that, yeah, I mean, we were being exposed to high levels of lead, and we are taking that home and exposing our families to it. And so we, implemented some corrective measures to reduce that. Now we monitor that. A method of exposing or of monitoring and checking for exposure levels and possibly mitigating and treating those things, not just throwing a disability at it, a disability rating. Let's get some treatment and see if we can make a life better.
Yeah.
Just a thought.
But I think using that also, Rick, like Nick was saying earlier, gathering data. Nothing
Yeah,
happens anywhere without an appropriate amount of data. We do that, we gather the data. That way we can better utilize that data for, like you said, initial first steps, veterans forward, and then using that
absolutely.
data to help everybody else.
That's right. Yeah, and that's the primary focus of this technology is the individual putting a tool in their hand that can do the same thing it's doing for a clinician and provide insights and promote healthy lifestyle habits, at least in the right, being careful to bifurcate what's clinical and belongs in the clinician's hands only and what should be delivered to the end user, anything relating to lifestyle, sleep, nutrition, environmental, relationships, anything that can help that individual on a day-to-day basis. One thing that I haven't seen done yet is the incentivization of healthy lifestyle habits, and so we can sort of gamify this in a way that anything positive that's done from the end user's side, even if it's completing an assessment, getting their labs done, improving their lab numbers because of the healthy habits that they've been implementing, journaling about their healthy breakfast, all of these things contribute to a trackable progress report and potentially a score that somebody can say, okay, well, I'm now implementing these things. My lab numbers have improved. They can watch it before their eyes change and their sleep improve, and then the numbers on their Apple Watch to prove it. As an example, I think putting that data first in the end user's hand and then letting them decide what gets shared to their clinician from a PHI perspective, and then as a whole, getting this massive data set to the institutional leadership that needs it, so we can start making changes, pay for the care that we can't get inside the VA.
Yeah. So, kind of coming back to our list of questions here, that kind of goes around a thing called grace that you have in your white paper. I had one of my providers say, do they realize they misspelled grace? Yes, it's an acronym. It's an acronym. And then I gave them the flyer. and let them, or I let them read the rest of the flyer. So can you tell us a little bit about Grace and how that's structured and what that is?
Sure. Yeah. I was kind of talking about it without talking about it, but Grace is the guided renewal and integrative care engine, GRAICE. This is the platform that is both first and foremost for the end user, for the veteran, and for the clinician. So for right now, for like small to medium sized practices, because this is a newer technology, we're launching it out into the ecosystem methodically and slowly. So it will be able to replace the EHR, electronic health record systems, for small to medium sized practice. Direct primary care is a good example, like, of the model that would fit this well, but also for more conventional primary care offices that bill health insurance. All of the above. The idea is to create the web of like longitudinal data for every patient, that can be consented and shared to the provider, and um, then their clinician can track the outcomes, without having to rely on, like, the once a year 15-minute appointment to actually get the data they need to come up with intelligent treatment solutions that consider more than just one side. Oh, you're presenting with X, Y, and Z symptoms. Well, my the literature that's 20 years old is telling me to do this, so let's throw that medication at it. It's it's a noble effort, but like telling somebody, get your 8 hours of sleep, or make sure you get your vitamin, like, that's not helpful, right? It's using sleep as the example, with Grace as the intermediary, the technology assisting both the clinician and the patient. It's going to dig down, right? Are you waking up in the middle of the night? Is it the same time every night? Or are you having trouble falling asleep? Is it a cortisol spike? Is it a blood sugar crash? Those are the
Is it
intricate details.
is it your inflamed prostate? It's,
Yeah.
yeah,
Yeah.
there's a whole
Right.
litany of things it could be. And chasing that down and fixing that root cause is a huge step in the right direction, as opposed to, hey, here's a sleeping pill.
Yeah.
Right.
Like you said, Nick, for them saying get 8 hours sleep. Hey, bro, if I could get 8 hours of sleep, do you think I'd be telling you I have a sleep problem? I would just have
Yeah.
gotten it, you know?
Yeah.
Yeah,
Yeah.
exactly. Exactly.
Right. Yeah. Yeah. And there's other things that, I mean,
Agreed.
it's lifestyle for sure. And that's where, like, the it starts in the mind. We as individuals have to decide, like, yeah, do I, I live in Buffalo. Do I want to get outside as soon as I wake up and get that morning light in my eyes? It would help, but there's no way I'm doing that. Like, it's 10 degrees below zero.
Yeah.
Yeah.
In the
Yeah.
wintertime, that's a
Yeah,
hard ask.
exactly. Yeah. Yeah. Right. But
A light that simulates that during the winter months. There's studies that show some advantages to having a lamp that simulates sunlight. So when you get up, if you get up before the sun comes up, especially in wintertime, and you have those, that depression that tends to set in during the longer nights, the darker and colder, especially if you're up north, that help mitigate some of those effects. And that's another option.
yeah, I need to get one of those. They're called full spectrum lights, I think. That
Like that.
is, yeah, that should be in every house, I think. That's amazing. So going back to Grace real quick, it's really about putting the uh, the ability to be proactive with one's health, with all of the data that they need, on the lifestyle front, direct to the patient, direct to the end user. On the clinical front, empowering the clinician to use all of the data that's just been collecting cobwebs sitting in somebody's chart 10 years previous that hasn't been dug up but is probably relevant, those sort of
Mhm.
things. So that's the idea, creating this network and web of clinicians that can now communicate, and with the patient's consent, share data. We can't even share data between VAs. You gotta-
Ex
Have a hard time looking stuff up, my own medical record. So I had my gallbladder removed several years ago, and I could not get access to the post-op report, the anesthesia report, and that's in my medical record. My provider could pull it up, but I cannot. And I think that's, that's an issue when you're talking about a program like this that can share the information between different providers that you get referred to and the actual patient who's supposed to, in theory, it's supposed to be his or her data. So that kind of talks around, I believe, you guys call it the Grace Wallet. Is that
Mm.
kind of the purpose of that, or is that
Well,
something different
it
that I
it is
misremember?
something. It's something different but related, and it goes back to, we have this data set, right, and it's going to surface modalities that should be considered, recommended, whether it be a lab that should be ordered, and I've had this play out even for myself, where I somebody will order a lab, right? And I look at it and I'm curious, so I upload it into the AI, and it's like, well, this actually reveals a trend based on previous information, and these are the other labs that you should get ordered. That's great. If I take that to my doc at the VA or elsewhere, unless there's a code assigned to that, and that they can bill against insurance, well, I'm out of pocket now. So,
Yeah,
and that's fine. I mean, a lot of people don't mind paying out of pocket, but this should be accessible to everyone, even those that can't afford it, right? This should not be reserved to the affluent that can afford the boutique clinic that will spend hours with them. So the Grace Wallet it's essentially like, think of your Apple Wallet, but or an HSA, but easy to use, where we take our resources, and this comes from both our nonprofit initiatives, philanthropic, charitable donations, fundraising in that regard, and also companies that sponsor it. Renew being a good example, as our telemedicine clinic, where we're committing like 10% of our retained earnings back into the collective pool of funds that can be issued to individuals, veterans being the first target for um, our efforts here, and putting that money for direct care into a wallet called the Grace Wallet. And also, it's a buy one, give one initiative. So if the average user pays for a subscription to Grace, then they're also contributing to the Grace index, or the Grace Wallet as a whole. And then the nonprofit board can distribute those funds and put them into individuals' accounts. And this is where I'd like to get legislation involved eventually, where we get dollars from the federal government put in those same accounts, in those wallets, the veteran integrated care accounts.
Yeah,
And then
that'd be
the
awesome.
veteran can then decide where they spend their healthcare dollars and how they receive their own treatment.
So this would cover treatments that maybe your insurance doesn't cover.
That's right.
So it'd be kind of set aside for that.
Yes. Now it's early on. This is
Mhm.
a concept right now. We're building the infrastructure out as we speak, and the ability to, for people to self-report if they're struggling financially. That's part of the whole health picture, financial health, right? Like, people,
absolutely.
if you're living in a constant state of stress because you're sick and you can't afford the treatment you need, that's
Oh my gosh, yeah.
that's a devastating position to be in. And so, yeah,
Especially if
that's
your
that's
medical costs are now impeding on your rent or mortgage or just daily other financial stuff. Now
Yeah.
it's like, what do I do? Do I keep a roof over my head or do I take care of myself? And yes,
Yeah. Do I take out a loan with an interest rate,
yeah.
and now my retirement's blown. I just spent it on this hospital stay that my insurance didn't cover, and or only covered part of it. I mean, that's a reality, especially as we get older. An inevitability that our health, we're going to have health issues as we age. That's part of the privilege of getting old. Not all of us have had that privilege. We've lost a lot of friends, family members, and however, when you survive long enough, something's going to break down, and it happens more the older you get, unfortunately, and it's harder to correct, and it costs more, and it puts people in a financial bind.
Yeah. 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 Being in that constant state like that, whether it be PTSD, financial strain, this just the mental strain of being ill in the first place. Talking about mindset, right? Like, the correlation between, and this is true whole health, right? It's not SSRIs plus a yoga class. It's understanding that every part of our system is controlled by our brain, like our brain health, our neurological system. And this is perfect. The concept of placebo and nocebo. The fact that you can take someone who has a fighter spirit with the same disease as someone who's given up, and that, the statistics prove that that fighter spirit's going to be the one that survives. Somebody who has a positive outlook, even like despite the things that are going wrong in their lives, being, having a heart of gratitude despite facing multiple challenges in life. These things are difficult when you have an inflamed brain, right? And your neurons aren't firing anymore, and you have TBI and PTSD. And so the first step is like, all right, let's figure out how to return us to a neuroplastic state and to free up. And this is literally what happens in the brain is now our neurons can move and start connecting again and cluster, and that's how we form new perceptions. We go from a mindset of defeat to one of victory. And it happens in the mind first, right? Be not conformed to this world, but be transformed by the renewal of your mind. That's my favorite verse in scripture, but it's absolutely relevant, and it plays out in the science that we know to be fact today.
Yeah.
Yeah,
So,
back in 2014, I went to the DoD Traumatic Brain Injury Clinic, TBI, for those that don't know what that means when Nick brought it up. And when I got back, I was on 52 pills a day. And I got tired of sitting on the couch with my daughter watching SpongeBob and just crying. You know, it's pretty emotional usually, but not every time. And then I decided that, you know what, and I took about 18 months and I worked myself off every single one of those meds and felt like such a better person, a better dad. And but the treatment that I received there, don't get me wrong, was amazing for the month I was there. But like you said, sometimes polypharmacy, sometimes it's necessary, sometimes it's not.
Right.
well, and I
Yeah.
think that in some instances that pharmaceutical intervention is needed, but is it needed for life? And that's what we often
Mhm.
see is that we end up with statins, SSRIs, beta blockers that people are on for the rest of their lives, as
Or like
opposed
Nick
to,
said, antibiotics for 6 years, which is
yeah,
just
that's insane, man.
crazy.
And so having that intervention when it's needed until we can figure out what the root cause is, and then we start looking at that root cause and how can we adjust that, and then taking that intervention back so that you can lead a more full, interactive life.
Yeah. We were talking about, I guess, novel modalities and the ability for us to afford them. Most of us can't. I remember learning about, actually, just as I was separating from the military, learning about Johns Hopkins psilocybin, and it's specifically for veterans, but it was $10,000 out of pocket. I'm like, oh, well, that's cool.
Yeah,
I mean,
I'm
I'm
out.
not going to do that. I'm going to ask my buddies if they know anybody, any jabroni down on the
Yeah,
corner that has them, because that's what I can afford. And
yeah.
the evidence is there, right?
How are you? How is the nonprofit funded? I mean, you mentioned donations, and how is this all of this funded? I guess.
So right now, the most important thing for us, because we are such a new entity, a new nonprofit, is the outreach, getting the ears of people at these institutions, going to the conferences where decision makers are, the leadership within the VA, within the DOD or DOW now, CHES, NIH, and talking to the right people who are of a like mind, who agree, like, yeah, I mean, I haven't talked to anyone who disagrees, by the way, not yet
Yeah.
anyway. But
Yeah.
getting the decision makers all inside the same room, starting with the leadership at this nonprofit and the veterans to start stomping our feet. We already are, but let's get the bullhorns out and start demanding change, and having, these institutions where their budgets are already hyperinflated. Let's take some of that, give it back to the veteran, and so we will be a conduit for that. We are lean today, of course, our minimal expenses. The other the other avenue for funding is companies that sponsor it, whether it be clinics who are, just charitable in nature. Our clinic, contributing 10% of our retained earnings back. And yeah, those couple of avenues besides donations will be the funding mechanisms.
Why did you guys start with veteran healthcare? Why is that? Is it just personal, or is there another reason? I'm just curious.
Well, it is personal for sure. Having not just myself, but quite a few members on the leadership team being veterans and knowing how fractured the system is today, it was just the obvious start, obviously giving back to the communities that we served and the one, that needs it the most in many different ways. So I can't think of a better cause than to start with the veterans who've served, who've like sacrificed so much, including their own health. They deserve a little bit of quality of care, and that comes in making some changes. I haven't talked to anybody that agrees. Like, yeah, I think 18 million veterans in the U.S. Only half of them go to the VA. And when they go, it's only because we have to, right? I guess
Yeah.
as little as possible.
Yeah. You got to start somewhere. And I agree. If you got to start, might as well start with a good cause. So thank you for that.
Absolutely.
Yeah. So you see this as being able to expand to other at-risk population.
Yeah. Yeah. This is the pilot of a project that will be able to extend to other vulnerable populations. And that's essentially what we're developing with our research layer, being able to take all of the data, doesn't matter the patient population, the demographic, where they're from, whether it be the difference in biology between a male and a female, or even, state to state where like we have higher obesity rates or higher cancer rates. Like here in Western New York, in Niagara Falls in particular, there was so much industrial waste dumped there that
Wow.
there's huge amounts of toxicity in the environment, increased levels of cancer. So as this network expands and includes populations from various demographics, we can now quickly just string together research and correlations and trends among populations of age and geographic, and you name it, really just filtering that out with a few keystrokes and being able to deliver the data that's needed in the institutions that can put resources behind it.
Yeah, that's awesome. So how how can how can people get involved? I mean, what can the average person do? What can the average provider do to get involved and support this? What's the way?
Great question. So I'm excited because there are already so many wonderful people joining in a collaborative environment from all over the US. Virtually, we have a monthly collaboration meeting right now. It may go more frequent as we grow, and we'll probably have breakout rooms too, where people who are working on a particular project or in a particular field within medicine or technology can get in and start having like roundtable type discussions and really start organizing. And it doesn't cost anything. We're not charging memberships. We're just trying to get people in the room and start planning on how to move these mountains. And so the best way is actually just to go to the website. It's AR Medicine, Alliance for Responsible Medicine, right? AR Medicine. There's options there for clinics to get involved, for partners to get involved, for veterans to sign up. All they have to do is fill out the form on the website. We'll welcome them into the community and just start talking, start planning. I say it all the time. It's just impossible for us to do this, even as just a few entities together. We need a broad effort, clinics to come on board and agree you know, to treat our veterans. I think like in the early years before we have like federal funding, let's say, I hope it happens sooner than later, but really just relying on the wonderful people offering their time, their expertise. There's so many that have already, even in the last couple of months since we've started, it's extremely encouraging. I can't wait to see what happens, a year or two from now. And I thank you, gentlemen. I really appreciate you helping us get the word out there. So if, people in your community are listening, go to the website, hit my email address is just Nick, Nick at armedicine.org. Send me an email directly. I'd love to have a chat. You guys are doing awesome things in the schoolhouse too. And then I appreciate you helping us get the out. That's the most important thing is the outreach right now, getting people inside the room that can plan and make a difference.
So clinics, providers, they go to the website, they can sign up, and what happens? What happens then? They sign up and they become part of the system, part of the program. What does that look like?
Yeah. There's so many opportunities right now where just about anyone can come in and lend their expertise, their resources. But from a clinic standpoint, one thing I forgot to mention about Brace, our software platform, and our collective mission here is to democratize precision integrative medicine, is that we've structured our revenue in a way that it's free to the clinic. So a it's going to be a world-class electronic health record system that won't cost the clinic anything. Right now, like a good software platform costs a clinic at a minimum hundreds of dollars a month.
What?
Yeah. And the larger systems are literally millions of dollars to deploy. Many fall in between. But if we can get this tool in the hands of clinics at no cost and have it work really well, that is our best effort at like just expanding access and their patient populations now being benefactors of precision medicine. And so on the clinic front, you have that opportunity, also the opportunity to just join us on these meetings and collaborate with industry leaders. We have, people from lab companies and AI experts and from all disciplines within medicine getting their heads together and just battling it out, figuring out what walls need to be torn down and what needs to be built up. So that's it, man. It's just, let's get inside the room. Let's start talking. That's the first step. Yeah.
I really recommend to everybody to go to armedicine.org and download the white paper. Nick's email address is on page 1 of the white paper, phone number. But read that white paper and see what it's all about. It was mind blowing. Some of the bad information you put out from regular healthcare, I just didn't know that stuff. I mean, but yeah, so great, good stuff.
I appreciate it. And clinics, I mean, when we first launched our telemedicine clinic, Renew, it was just a thought in my head. And I put an ad out on Indeed's job website. And I was like, well, I don't even know if anybody's going to sign up, if clinicians are going to be interested. I'm just, who am I? I'm just an engineer trying to figure out how to put some tools together. But we had 300 clinicians apply within a week.
That's impressive.
And yeah, I think we interviewed maybe 50 of them and talked to many more. But a trend I noticed was that the majority of them, if I'm remembering, is trying to escape their conventional practice. And there's stats out there you can look up. I think it's gone down the last couple of years, but the burnout statistics among providers who went to school, signed up to help people heal,
Mm-hmm.
and now are part of a system that's just driving them into the ground. And whether it's just ridiculous hours, a hospital system that prioritizes administrative over patients, that are looking at, well, does that treatment plan have a good ROI, and the hospital insurance companies making a decision for the doctor? Like, that's an absolute insanity. And it's one of the reasons that there are poor outcomes, first of all. And you take the amount of stress that the average clinician takes on their shoulders, and their patients aren't getting better, and they're just getting, herded through this system. People are leaving medicine in droves. The AMA put out a stat, like roughly 30% of clinicians are thinking about leaving medicine altogether, or have thought about it in the last couple of years, and
Which is a
are
high
just,
number for somebody who's put 7, 8, 9 years into
yeah,
becoming a provider, and now they're saying the system's broke. I can only do so much, and the
right.
wait, I'm out. I mean, that's
Yeah.
the hard and yeah,
Well,
I
I mean,
agree.
the stress behind it affects their lives, their health, their families, their quality of life. And at some point, they're like, "Hey, man, I just can't do this anymore." We have a shortage of certain specialties just because they're either cost of training, the length of training is so long, and the shortage causes a patient overload. And there's all these contributing factors. That's a larger factor that I think we can actually tackle, but looking at what we can do to make things better for the providers, for the patients, I think that's a huge step in the right direction. And I applaud your effort in this. And I hope this
Hmm.
becomes successful and that it becomes widespread and becomes a true, vehicle for change.
Thank you. I appreciate that. I appreciate your sentiment and the collective mind here that's really putting our effort forward. We've had enough, right? Not just
Yes.
clinicians, but we as patients also. You know, there's the money is there, right? The VA doesn't have a budget problem. I think really it's just the how that money is being spent and the direct delivery of care, medicine to patient, not all of this hyperinflation in between. It's not a lack of people agreeing that it needs to change. Let's put it that way. That the agreement is there. It's just we need someone to organize, and so
Yeah.
that's the
You
effort.
brought up, you thought the VA's budget was 400 billion. I looked up in 2026, it's 441 billion. So you're right. The money's
Okay.
there.
Yeah.
Help, like you said, fix us or let us help fix ourselves. Two
Yeah.
choices.
Yeah. Right.
But is there anything you want to add in closing?
Yes. So I just want to give a quick shout out to all the wonderful people that have joined this cause, including you gentlemen. I really appreciate the opportunity to let me come on here and spread the word to your community. That the Special Forces medical community is like the best example of how we need to make changes in medicine, and everyone I talk to in your community agrees. Like, if the VA is not going to do it for us, we're going to find a way to do it ourselves. But I hope that they can get involved and help fund some of this. Thank you to the entire team at the nonprofit arm at Renew, who's building out the software. Thank you to the engineers, the people dedicating their time, the advisors. We couldn't do it without everyone collectively in the room, and including you gentlemen. So thank you very much.
Thanks for being on the show. I know time is money, and you spent a fair
Yeah.
amount of time with us, and we appreciate that
Yeah.
too.
No, we
I
really
loved it.
appreciate.
It was awesome.
Yeah, we really appreciate the organization and your efforts and the goal behind this. We totally support it, and yeah, it's our pleasure to sit down and hopefully get this at least out there a little bit as much as we can. Yeah, we
Thank you.
wish you the best of luck moving forward.
Hmm. Keep us posted.
Awesome.
Definitely
Thanks.
keep us posted.
Absolutely. Yeah. I'll keep you guys as part of the regular updates.
Mhm.
Thank you.
Yeah, we appreciate that. All right, well, I guess everybody that is watching this, thanks for hanging out. If you get a chance, go check out the website, uh, armedicine.org, and yeah, help support the cause. Thanks again. Take care.
Thanks, everybody.
Thanks for tuning into the podcast. We'll see you next time.